David Dukas. I'm the director of the Division of Medical Humanism and Ethics here at the University of Louisville. Very important point, and that is that all three of the lunchtime lectures are web streamed. They're web streamed both at our website, which if you just go to any louisville.edu domain webpage and put in the word humanism, it'll take you straight to the Division of Medical Humanism and Ethics, and will get you to the Gaines Lecture Series, which this is part of. It'll get you to the Stambaugh Lecture Series, which is the one on humanities, which Jack Houlihan will be doing, who's one of the greatest poets of our time, physician poet, will be coming in April. And then also the Chang Lectureship in Medical Ethics. So they're at the humanities webpage on the left-hand column. When you get to our page, you click on that link and it takes you to them. We have data warehoused all of the lectures since February of 2005, so you're able to see them anytime you want. Secondly, all of these lectures are on iTunes, special iTunes University. So if you go to iTunes, there's actually a tab saying iTunes University, and it's a place where you can podcast all kinds of neat stuff. I mean, if you want to go ahead and take a look at a lecture at Yale or Harvard, yes, and just as good here at the University of Louisville. All of the lecture series, again, going back to 2005, are on iTunes University, where you can then download them to your iPod or watch them on your computer. And you can actually go ahead and subscribe as a podcast so that every time they're uploaded, it'll be downloaded to your computer or your iPod. Isn't technology wonderful? So now moving on, as I mentioned, Dr. McCullough, who is out of the room, this is Dr. McCullough in the back row, who will be speaking tomorrow on medical futility, which should be very exciting. Today I'm very pleased to introduce Dr. Stephen Ware. Stephen is a friend and colleague and also a collaborator. He is working with me on the PRIME project, which is the Project to Rebalance and Integrate Medical Education, which is a curriculum reform project looking at medical humanities and medical ethics in medical schools. We will be having the second phase of our project, which is a working group meeting of a small cadre of us of about 20, but it will be including the heads of AAMC, ACGME, and LCME. These are all the accreditation bodies in education. They have all decided to throw their hat into the ring in helping us, and they will all be part of the national conference, which will take place here in Louisville in May 10th and 11th of 2012. You are all invited to that. So that should be a very exciting conference because we are hoping to make some very evolutionary and perhaps revolutionary proposals of change on how medical ethics and medical humanities should be critical and required throughout the medical education of physicians. Dr. Ware is coming to us from SUNY Buffalo, the State University of New York at Buffalo. He's been there since 1979. He's an associate professor in the Department of Medicine at SUNY Buffalo and is also an adjunct at the Department of Gynecology and Obstetrics and the Department of Philosophy there. He's the co-director of the Center for Clinical Ethics and Humanities in Healthcare at SUNY Buffalo. He has also been a visiting scholar at the Hastings Center, a research associate at the Kennedy Institute, and a fellow at the Institute for the Medical Humanities at the University of Texas Medical Branch at Galveston. He received his BA in philosophy at Windham College and then went on to his Ph.D. in philosophy at the University of Texas at Austin, where I guess that's where you met Dr. McCullough. That's correct. And later became his best man when Larry got married. So I'm very pleased to introduce to you today Dr. Stephen Ware, who will speak to us on producing and evaluating and implementing advanced directives. Dr. Ware.
Thank you, David. How's the acoustics in the back of the room? Good? Okay. Excellent. My focus is on advanced directives, and I was instructed or it was suggested that the Gaines lectures should be clinically useful, and hopefully you'll find I'm intent on doing exactly that. This is something I've worried about for quite some time. It is, for bioethicists, one of the main ways in which we would hope to impact on end-of-life care and it not being abused, or however we want to put it. It also comes up for me. I consulted various hospitals, particularly the VA Medical Center in Buffalo, and we get quite a few of these. I'm not sure if you're aware, but by federal law, every patient that's admitted to a hospital has to be asked if they've got a health care proxy and a living will, so we end up with some information in that regard. Hopefully, if they say yes, we exercise ourselves to get those documents. A lot of stuff comes in, and as I was just saying to one of you, part of my problem is some of it, a fair amount of it creates more problems than it solves, so I'm going to worry about that a little bit too, okay? It's something that there's a lot of hopes that it might carry a lot of baggage, and I think it can, but I think we have to think a little bit about how that could be done, how to, for example, with health care proxies, to empower them, to inform them, and get them to the point where they really bring something in the room when the time comes. Now, let's see, how do I guess I just click this. Aha. Let's see if this works. Okay, issues regarding advanced directives. First, why bother? We need to get a little clear about that. In fact, what are our objectives with these? Second, what sorts of advanced directives are available, and what are the strengths, weaknesses, and variable applications of the different types? It may make sense that different patients need different things, different approach. Some patients also may be more comfortable with one type of thing than another. 3, aside from monitoring for previously executed advanced directives, are there considerations in evaluating the ones we are presented with? Okay, I'm certainly going to be one of those that says, if in response to the question, do you have an advanced directive, the patient says yes, we get a copy of it, throw it in the chart, that we need to do a little bit more than that. Shouldn't surprise you, I'd say the receiving team should take a look at it, make sure it makes sense. Probably even if it does make sense, they should go out and ask the patient if this is still what they've got in mind, or maybe even more simply, why did you execute this? What was the situation? Is that still the person you want as your proxy? Stuff like that. Okay? And other questions like, does your proxy know that they've been named your proxy? It's always fun to talk to somebody at 2 o'clock at night when the patient's crashing and burning, and then they say, huh? As in, what's a proxy and when did I get nominated for it, right? So there are preventive ethics things that we have to talk about. 4th, are there patients whom we might actively encourage to execute advanced directives? If so, when and which? As you may or may not know or have experienced, if any of you go to a financial planner, and I know this is true in New York, and one of your colleagues just indicated it seems to be the case in Kentucky also, among other things, it would be considered, this is what one of them told me, malpractice if they didn't strongly encourage you to do a proxy, and they'll give you I see a number of you nodding your heads, various advanced directives. So that's a source for them. I'm not sure, actually, I'll ask a question. The question is, how proactive and aggressive are hospitals about advanced directives? More specifically, let's put it this way. At the VA Medical Center, we ask them if they have these documents. If the answer is yes, we get some information as to where are they, make suggestions about getting those documents in. We have the electronic medical records, so we can scan them right in. They're immediately available. If the answer is no, the next question, and this is right in the admission packet, would you like to talk to somebody about it? And if the answer to that question is yes, again, we got admissions personnel here. They're only willing appropriately to get so clinical about something, but with little prodding and being nice, they're willing to ask the question. If the answer is yes, a view alert is sent to the social worker or the receiving team, and they will respond to this. Okay? Certainly, as far as the proxies go, I would hope any of these that would be suggested, I'd like to see one from everybody we can get our hands on, and their brothers. But anyway. So those are the questions. By the way, I've got a number of things to lay out here, but I certainly want to say, if you feel moved to jump in here and clarify or raise a question or whatever, please do. We can get to my agendas one way or the other. I gather we actually have an hour and a half here. I don't know how many of you have that much time, but we're scheduled for that.
They usually go around one, not just
but you usually go around one. So I'll try to do this pretty quickly, but if you're moved, jump in. Why bother? Well, I think we all sort of know most of this stuff, so I'll just go real quick. There's a perception of overtreatment at the end of life. Okay? Advanced directives try to meet that. If we got a patient that's bright-eyed and bushy-tailed and can tell us yes or no, then our issue is really, are they well-informed and have they heard what's going on? But in the end, I assume we're all in the 21st century and we're willing to go along with the idea that patients can refuse treatment. Okay, as one patient said to one of my residents one time who was kind of pitching him to get intubated, this is a veteran patient who'd been intubated before. She gave him the whole pitch, and at the end of it, the patient just looked at her and says, "Doctor, what part of no don't you understand?" And at that point, I kind of tried to point out, that's really kind of a bingo. I think we got to go with this, right? However, patient autonomy rules, and it's really just a process of making sure the patient isn't making an uninformed decision. But the problem is often when the issue arises of aggressiveness of care, should we be aggressive with this patient, whoever raises it? Often, I think that I would guess the majority of time, the patient's no longer available for comment. Okay? So we no longer have the gold standard. The gold standard is patient says, that's it. Forget about it, right? We don't have that. Then what happens? Well, we move to family, right? Traditionally. But, you know, unfortunately, well, if your family's anything like my family, we're not overly sanguine about that, right? There are families and there are families, and, right? So just going by what the lawyers offer us, and I'll get to this later, you're like New York, Kentucky is like New York, you have a ranking surrogate list. If the patient's not available for comment in the judgment of the attending, then we go to a list, spouse, adult kids, et cetera, right? But that doesn't really work for everybody, right? And we'll get into that. Why doesn't it work? Let's say. Oh, actually, here's the list right here. Traditionally, regularly, go to ranking next to kin. This is for Kentucky. Spouse, adult kids, parents, siblings, and then, according to Dr. Dukas, whose word I'm going to take on this, anyone with a shred of your DNA. Now, that's a little... Yeah, right. In New York State, grandkids and grandparents are mentioned. We have a category called close friend, which is somebody that knows the patient. They have to prove it. Do you have a close friend category?
The hospital does, but not the state.
Interesting. That's, to my mind, really unfortunate because we end up a lot of times all we got is the close friend. By the way, one of the rubs here, I don't know what it's like here, you may be less inflicted by lawyers. How could I say that nicely? Well, inflicted will have to do, I guess, than we are in New York State. But if you don't have any the people in the categories, then you have to go to court. It takes a lot of time, et cetera, right? Interesting to note in that list, which I assume, like in New York, is not just for death and dying stuff, but it's for any informed consent. I always like to point out, because some of my residents don't get this, cousins, nieces, nephews, uncles, aunts, et cetera, aren't on this list. What's that mean? Consents from them aren't worth anything. Once had a very creative, smart resident who teamed up with an equally creative and smart social worker for a patient that we couldn't find any next to kin. They called the third from last town that he lived in It turned out it was where he was born, and started calling every home in the phone directory that had his last name. They finally actually identified a second cousin, okay, and got consent to major surgery from that second cousin. And it was, and the chart note was great. It was one of those residents that writes beautiful chart notes, and among other things, made very clear that prior to us contacting him, the second cousin didn't even know the patient existed, had never met him, et cetera, et cetera. Anyway, so there. What? Yes?
I just wanted to let you know that if time permits, I have a case that I actually just left that is extremely unusual, and if we're using this as a forum to discuss the problems with advanced directives, I'd love to share that with everybody at some time because I could use some help, but whenever you would like me to share that, I'll leave that up to your lecture.
My instinct is to save it for discussion and kind of prime your pumps here.
Okay, that's fine. I have to leave at 1 though, so I.
Okay, well, let's.
That was the only thing that I just wanted to bring up.
Okay, tell you what, let's try to incorporate that then. Let me get a little further here and lay out some of the stuff.
Thank you very much.
Okay. Anyway, problems with this. That is going to. In effect, what the lawyers got together and decided what's the common sensey ranking of surrogates, right? That's what they gave us. That's not necessarily what it might be in your own family. It's like, you know, if you die intestate without a will, they'll divide it up among your 3 kids. If you thought to do a will, you might have cut out Junior, who's been a jerk for a long time, but you didn't get the chance to, so Junior gets it too. Problems with this, that is simply relying on a statutory list of surrogates. Legal uncertainty, that's more of a New York thing. You're dealing with the heirs, which should make us a little nervous, right? You're also dealing with dependents, at least in New York State. We have some, veterans who have nice steelworker pensions that are supporting extended families, and those pensions go bye-bye when the patient dies, right? Inability, there's all sorts of inability. I've certainly run in any number of families. I'm sure you have too. The idea of signing off on dead is just not something that they can do, and they will tell you that. There's ways to respond to that, I think, but disagreements between surrogates of the same rank. On a quick read, we could have any number of kids. I once walked into a room of a patient where even with a small family, it was going to be difficult sorting out what to do for this guy, whether to be aggressive or not. It was not a no-brainer. And there were 9 kids in the room. One was an international investment banker that flew in from London. Another was a longtime Hare Krishna devotee that flew in from Mumbai. There was a CCU nurse in there, and then miscellaneous other folks. And I found myself thinking the possibility I'm going to get unanimity or anything close to it from all these folks on any issue whatsoever is so, right? But actually we did, but I won't waste time for that. And then there's bad folks out there, right? Have we all noticed there's bad folks in the world, and sometimes they happen to be the ranking surrogate, and we can tell, but we can't prove it? No, I'm not coming in. Just keep them alive. Folks that will keep Uncle Al alive just for the sake of $25 a month disability check. Because it's money and they don't care at all, right? And usually we can't prove it, we suspect it. Final thing is, I think there's a growing recognition over the years that there are individual choices that can be made here. You take 10 people that have metastatic disease, half of them of a certain type, half of them will go to the Cancer Research Institute, and half of them will go to hospice, right? And there's nothing in the medical description of the case that tells you which way to go. You need to leave an area for that. And a lot of that has to do with experiences. Their experiences, their family, their acquaintances, what happened to them. Solutions, there's a bunch in the advanced directive area. One is a healthcare proxy. That's simply usually a one-page form, and in effect the patient says, if I can't speak for myself, I want so to speak for me. A living will, well, I'm going to show you pictures of these shortly here. A living will is something different. That's when the patient tries to anticipate a scenario and says what they do or don't want if that happens. It's conditional. If this, then that. For example, if I end up in a persistent vegetative state, I would want to be kept comfortable. I wouldn't want to be treated aggressively, right? Language like that. This is the sort of stuff that you'll have the option of doing this if you go to your financial planner or if you want to run into one of my social workers. More poetic, values history. I'll show you a picture of this in a second. This was developed primarily by Dr. Dukas and Dr. McCullough. And this is something, I call it more poetic. Basically, they're asking more stuff about goals of care and what a person thinks about their life and what they value and don't and all the rest, okay? Another option, which we could argue about whether it's an advance directive or not, would be MOLST. This is medical orders regarding life-saving treatment or out-of-hospital DNRs. Why we might not want to call them advanced directives would be that there's nothing advanced about them. They are current. They are current. This is stuff that's out in the community. It's on the refrigerator. If you bring it, if it's brought in with you to a hospital, legally they're pretty much obliged to honor these things. Okay? So it isn't like you get a living will in and you've got to interpret it. You've got to talk to the proxy about how to interpret it and the rest. Okay? This is an order that's done, and all that you have to assume is some clinical colleague, these have to be generated by doctors, some clinical colleague had an appropriate discussion with the patient and decided that was going to be the case. Okay, so a lot of times these will simply be honored. I assume you've had this for a long time, simply like we have in New York State. For the longest time, we would get DNRs in from patients that came in for something from a nursing home. It'd be part of their package that would show up. And we had the option of simply honoring that, of instituting that order in the chart. And then finally, there's various verbal prior statements, discussions. This is Grandpa at Thanksgiving dinner talking about how, don't let them do what they did to Uncle Al to me. Okay, there's legal status to that. Now, let's see. I'll just show you some pictures of these. This is the healthcare surrogate. This is, or agent. Nice and simple. In New York State, I don't know if it's here. Doesn't it? Blah, 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 blah. And you've got an alternate. They ask for other things like phone numbers and the rest, but that's it. The other option is something where we actually do a living will directive. And here's three things that you'll often find in these documents that patients, some of them tend to say, if that happens, I want to be treated non-aggressively, kept comfortable. One that most would agree would be permanent unconsciousness. The other two you often see are terminal condition or no longer have decisional capacity. All right? And then you can check boxes and things like that. This is an example of the values history sort of questions. As you can see, I call them more poetic, but it's something beforehand, before something big time happens to the patient. It's not just what they might say, but it's also a stimulus to them to think about things, right? So you can imagine giving somebody this and telling them to think about this, talk to your family about this, come in next time, we'll sort it out, okay? Let's all pick a proxy, okay? Let's take a poll first, actually. How many of you have healthcare proxies appointed? Okay, all right. That looks a little bit above average. My experience in New York, and we're fairly aggressive, is somewhere around 25% maybe. What's the average down in Texas? McCollough, you got any idea? Okay. And usually if there's a proxy, there's a living will. How many with living wills? About the same number. Just at some point to aggravate you all, I'm going to suggest at the end that maybe you don't need those, but we'll talk about that. Is everybody clear? Actually, let's go back here. Is everybody clear as to if you... Oh, stop. I guess it's not going to do that for me. Okay. Here's the ranking next to kin. Is everybody clear if you suddenly became incapacitated, who we'd have to be calling for you? Anybody have any question about that? Okay. For what it's worth, you may think, well, yeah, I'd go with it'd be that person, and I'm completely comfortable with them. Suggestion. In my experience, staff and others tend to show more respect when they've actually got a designation by you rather than just that's the ranking surrogate, as the lawyers say. So there's still a reason to designate a proxy. Okay? All right. Those of you that don't have one, I want you to all take a millisecond and choose who's going to be your proxy. Time's up. Okay. Now, let me debrief you quickly. Give me some help. Why did you pick who you picked?
I went for the default spouse. Out of everybody I could think of instantly would know the most likely. I'm not sure he's actually the best choice because he's also the most likely to be distraught.
Well, is he the best choice? I mean, one of the points of a proxy, by the way, for those of you that saw the legal ranking, is to pick somebody else. It's not unheard of for a spouse for somebody to pick somebody other than their spouse. Like, I've designated my secret girlfriend, okay? That's going to cause problems when the time comes, but I won't care. Okay. So should you rethink that? Would there be somebody better? And if so, why? So, let's see, distraught. So maybe inability to do the job. Right? Okay, what else? We can go either way. What are reasons you picked the person you did? Trust. Trust for what?
Trust that they will make the decision, know you well enough, and will have the ability to make the decision, the right decision, the one that you would want to make.
Okay. Notice what he's saying in part. Know you well enough. What are we most looking for in a proxy to do?
Make substituted judgment.
Making it easy here. Substituted judgment.
You got a ringer for palliative care.
What's that?
You got a ringer for palliative care.
Okay. If you think about it, I've actually said this to patients, to families, in certain ways. You need to understand what we're looking for from you, okay? We're not looking for what you would want if you were in Uncle Al's shoes, because you're not, okay? Neither are we really looking for what do you think is best for the patient, because that gets pretty complex, and arguably the doctors might know a little better about that. But what we certainly are looking for from you is, given all that we just told you in real time, in real detail, not some, vague terminal illness, right? But we just told you what this means for the patient, what we can do and all. What do you think Uncle Al would say if he heard that?
Quinlan question, right?
What's that?
What the Quinlan lawyer posed. If Karen could be here right now, what would she say?
And there's a real mercy to that, by the way, if you think about that. Okay? A lot of people won't do it because it's like they're signing off on Dad. They're embarrassed by that. What'll the family think? What'll the neighbors think? Et cetera, et cetera. But you ask them, well, what would Dad have said if he do this? And it's funny, I've had a number of circumstances. Actually, I really learned what substituted judgment meant one time because we had a wife and 2 daughters. And the patient was somebody that was very much end of life, actually a former administrator at the hospital he was in. And they had been appropriately approached by staff about do not resuscitate, then moving to comfort care, and had completely rejected all of that. And at some point, I stumbled into this was back when I was 1 year beyond being a green graduate student. And at some point, I just stumbled into it. I don't know if I even knew the concept of substituted judgment then. This was early 80s. I just said, well, what do you think he would say if he heard what we just told you? Oh, he wouldn't want any part of this. He would think this is crazy. That's a quote. He would think this is crazy. So, all I had to do was basically say, well, okay, I believe you, staff believes you, that's enough for us. And I can remember the wife saying, is that all? Is that all? I says, all you have to do is, if you're sure what he would want, if you're willing to honor that, we are too, be glad to. If you think about that, arguably it lessens one of the burden of any staff, of any family that walk out of the room. I actually get unhappy when I hear staff asking families, what do you want? I want to slug them.
Because I want them to not be sick. I want them to not be dying. If that happens, we'll be all good.
Yeah. Other reasons why you picked who you did? Or didn't pick somebody else?
I would say how impressionable a person was, so how influenced they could be by the staff. So I want somebody who's not easily swayed.
Okay. Do you want somebody that can stand up to the docs if the docs have an idea that may not be the best one? Okay. What else? Yeah.
Somebody that can deal with the screwy family dynamics.
Deal with the screwy family, did you say?
Yeah.
Okay. You got a family like mine, or you know them? Okay. All right. That's certainly important. What else?
Somebody I can talk to is alcoholic.
Ah, okay. Because it isn't just by osmosis that you do substituted judgment. It wouldn't seem like. By the way, there's some sense in my literature of people thinking that all we have to do is really ask patients these sort of questions about what do you think about PVS or terminal illness and the rest. And if we just answer them, the answers will come forth. Do you all think people have that all kind of sorted out? The answers are there. All we have to do is document them? Okay. The ones of you that are going like this, that's the correct answer. Okay. So we're being more creative. Other, please.
Many times the patient will pick somebody who's absolutely not the right person. I've seen that in my family. Because when it came, they didn't have the ability to make the decisions, yet they were the oldest.
Yep.
I had an older sister. She wanted to have my mother's in a nursing home in '92. She had a bleeding disorder. They wanted to take her down and have her transfused. Well, taking her from where she was in the nursing home down to the hospital to get transfused probably would have been the end.
Okay.
Just making her NPO and cutting back to let the intestines relax, and she went on for another 4 years. But she would make decisions that just were not. Finally, I said, pretend I'm mother and ask me the question you just asked me as if you asked mother, and she did. And I said, mother said no, didn't she? She said, yes, you're right.
Interesting. Okay. Yeah, there's something that I'm ambivalent about. That is, say you've got 3 kids and one of them's a healthcare provider. Is that an advantage? Okay. And on one level, I think, well, again, it depends on the person. We've got standing up to doctors. We've got some staff that are capable of doing that, and some that it's the last thing that ever think of. I'm ambivalent about that. I think, again, there'll be no scarcity of clinical people to paint the picture when the time comes. So arguably, that isn't what's needed. What's crucial is who has the best ability to guess what Dad would want, right? So I don't think that dictates. It might be helpful. But again, it's the patient that's going to make the choice. What I'm anticipating here, there would be scenarios where you might be encouraging patients to do this, and what are some of the considerations that you might help them think about as reason to pick somebody rather than somebody else? Okay? Other reasons you picked who you picked? Please.
I think one of the complicating factors that we went through was religion.
Okay.
It's not true, at least it wasn't in my case, but in some cases where I've seen it, it was true.
Yeah, one of the scenarios we will get at the VA, I've run it. Well, the simple scenario would be where we've got some patient that comes in and their family are Jehovah's Witnesses. Okay? They're not a practicing witness at all. They need a blood transfusion. Okay? That becomes a little strange. Another one that we had that was really tough, just the family dynamics, it was a non-practicing Catholic, and his two sisters were, well, let's put it this way. They were very unhappy with the American bishops who weren't following the letter of the law regarding artificial feeding and hydration, et cetera, that the Pope had recently made crystal clear. Okay? So the problem there being their views, it looked like there was no reason to think the patient had any of them. And I remember actually pushing them, and they'd start saying, well, we believe, et cetera, and saying, actually, I'm sure at some point I said, it's not germane what you believe. What's germane is what did the patient believe, and I'm getting the sneaking suspicion that his faith did not match the one that you're telling us about. And one of them actually admitted to that at one point. Anyway. Moving along so we can get to your case, sir. Remind myself of what I absolutely had to do. Running through it real quick, just relax. The health care proxy should meet legal criteria. Competent adult, 18 years old, be willing to speak on your behalf. That's important. We get proxies that say they wouldn't want to do it. I've had wives say, I couldn't, don't ask me. Be willing to act on your wishes. That's important. Okay, I've certainly had families that's not what they wanted to do, but they were willing to say, even though I don't like it, Dad would have wanted this. And then you have to help them a little bit to honor that. Be able to separate his or her own feelings from yours, live close by, or be willing to come. I guess so, although we've had quite satisfactory conversations by telephone across the continent. If it's really the person that is best able to express your wishes, then arguably, again, we can make those phone calls, and if they need to be, maybe they can come. Know ye well. Understand what is important to you. That's maybe part of where this values history might come in. Okay? Be willing to talk with you now about your sensitive wishes. Not everybody can do that. Willing to listen to those wishes, be able to work with those providing your care to carry out your wishes, be available in the future, be able to handle potential conflicts between your families and friends. We've already mentioned that. And be able to handle responsibility. Right? Okay? When might a provider encourage a patient to name a proxy? Anybody want to volunteer when they've found themselves thinking, this patient needs a proxy, I need to prod him? Yeah.
I can think of any number. One is, patient is married but separated and is for 20 years and doesn't like his wife, or husband doesn't want them making decisions. One is family members.
There's a lot of that.
Family members say, I am absolutely not willing to carry out whatever it is that person wants.
Or a little more subtly, where clearly, it's the old thing, it's the patient has the disease, right? They're coming to terms with what's happened to them. That's clear. It's also clear the family is not at all. And they may not be that frank in saying, we don't care what he says. I've heard that. I don't care what he says. He didn't know what he's talking about. But something more subtle. It isn't like you have to insist, but you might I mean, I'm certainly presuming to suggest that's a point where you sit down with your patient and say, you know, I got a distinct impression that your view of what's going on here and what we've talked about is different than what the way your wife is seeing this. And as a matter of fact, to be frank, I'm not sure she could honor your wishes. Okay? Would you like to consider naming somebody else? You have said others.
The last one I could think of is someone who just doesn't have any DNA strands floating around and you can contact. So someone who has no family, you know, it's kind of an awful lot in ethics.
Who might still have a close friend. That's why that legal concept is a good one. I mean, we've even gone out, reached out to landladies. If there's a relationship, if it's just a check every now and then. It allows you to reach out to nieces and nephews. Have you noticed, particularly with our bachelors, they often will develop good relationships with the children of their sibs? And a lot of times they have lousy relationships with their sibs, but the sibs would be higher ranking. Actually, they would be the only ones ranked. But the niece or the nephew is the provider in the community, runs interference, brought them in the hospital, make sure they do their meds. A lot of people do that job. So arguably, whenever you see that, you'd want to say, by the way, would you like them, if you can't speak for yourself, to be your primary decision maker? Isn't that an indication to do that? Shouldn't we always do that? Okay. All right. Yeah.
Another situation is that in which a patient may encounter a live-in surrogate with his significant other. And this is a long-time relationship. Well, in effect, most of us would consider this married. But in Kentucky, they are not married.
For the microphone, repeat it.
The question is basically when we have some evidence of somebody in the community that's got a long-term live-in relationship, okay, that person, they're not married in Kentucky and they aren't either in New York. Although interestingly in New York, we've had a change in the surrogate list, and equally ranked with the spouse is a concept called domestic partner. Okay, so they are actually there. All right,
so that allow for gay couples,
yep,
lesbian couples, as well as more traditional heterosexual liaison. But these are typically the people who know them best.
Yep.
And we've run into situations where, because of legal restraints, they could not serve in terms of the priorities listed on Kentucky statutes.
Yep.
But that's the person who needs to sign up for, this is my proxy.
Yep. In AIDS services in Erie County, Buffalo, and I bet AIDS services are its equivalent down here, every one of those patients that they bring on board, one of the things they strongly encourage, just short of requiring it, is that they name a proxy. I mean, think of the scenario. If they're gay, by the usual ranking in New York State, the lover would have status, actually, if they could prove it. In your state, they wouldn't, so what happens? Well, you may end up, there's a good chance you'll end up talking to the parents, who may very well be, even though it is the 21st century now, don't know the patient is gay, don't know they got HIV, and the last thing they're going to allow is to let you talk to the person you most want to talk to who gave my baby AIDS, right? Got it? That's the way that works out. Okay, other scenarios where you would feel motivated to say, Mr. Jones, you really need a proxy.
I think everybody needs a proxy.
I'd say the first time you meet her, that's the answer.
You anticipate. See, the way I'm kind of working up to this, you guys do that. I've got a few more, and at some point I'm going to say, well, therefore, everybody needs one, for Christ's sake. I mean, I tell my residents, when you go out and you're taking on a new patient, once you've hung up your shingle, among other things, get a proxy from every one of them. And the nice thing about that is if they say, oh, is it more serious than I thought? Am I dying? Blah, blah, blah. No. I do this with everybody.
You normalize it.
You normalize it. You got it. David?
Part of the way that I normalize it is I tell, when I do this, I'll say, I do this for everybody who's 18 years or older, who has the ability to make their own decisions. And look at me strangely or puzzled because they're in their 20s, let's say. And say, well, a lot of the really big famous cases were 21-year-olds, 28-year-olds who went into persistent vegetative states, and if they had had a proxy, it might have dramatically changed the way things would have worked for them and their family. So it is in your best interest, and I tell the students this too, is that if you're a medical student and you flip over your car on I-71 and there's no identified proxy, there may be a grave impediment in terms of what will then happen in terms of subsequent treatment. And it can cause treatments that will be imposed upon you that you would not want yourself.
Okay. Tell you what, moving quickly, mindful of you.
Yes.
I just think this is an interesting point. But if you don't...
No, that's all right. We'll get you in here. We're going to do that. Real quick, indications for naming a healthcare proxy. I think most of this we've got. Patient may not want the next of kin who's highest ranked. We may need a tiebreaker. With those 9 kids, I certainly would have suggested that. I've done that occasionally. I remember one lady, there were 4 kids. And she thought about a second. She says, no, I'm going to name them all. They'll get to deal with this as a family just like everything else, which was fine. Gay HIV patient, care provider not ranked. That's your nieces and nephews, whoever, right? Whenever you see that, I'd say that's an absolute indication to ask them. Ranked surrogate is problematic. It's tough if you think the wife is demented making the diagnosis because they're not your patient, right? That's problematic. But you could always suggest that the patient, should we be talking to your wife? Blah, blah, blah. Credibility with healthcare professionals, I mentioned that. Even if the ranking comports with who you want, helps to do the proxy, a little more weight to it, right? There's empowerment and permission here. People that feel nervous about this, I wish I had a dime for every time I told a family, I said, look, this is tough stuff. It's kind of a guessing game. I know you didn't talk about this. But one way to think about this, the patient said we should go and ask you, do the best you can with that. Do the best job. That's all you can do. Make your best guess if you got one. Some of them don't. Some will sit there and say, I have no idea. Small minority, actually. I mentioned lessening the burden by substituted judgment. We've had other indications. Any final one that we've missed here? Moving right along. Living wills. Really quickly, the typical verbiage, 3 categories that I generally run into: persistent vegetative state, terminal illness, loss of capacity to make own decisions. Which boxes would you like to check? When might you encourage a patient to reconsider all of this? Those are conditional. If this happens, then I don't want to be treated aggressively. There's unconditional stuff. There's Grandpa saying, don't put me on a vent like they did Uncle Al over the Thanksgiving dinner, right? We get that. We got a lot of Camel smokers out there coming in with their bilateral infiltrates. And it's interesting how many of them have said something like that, because one of their buds went in 6 months ago. And they don't want any part of that. And they'll say, don't let them do that to me. But the problem, of course, is they have acute reversible infiltrates that arguably, if we put them on a vent and give them antibiotics for 7 to 10 days, we get them home like the rest of these guys for another 2, 3, 4, 6 years, right? So that's problematic. I'm sorry, what did I do? Did something wrong here.
Put a slide.
F5. Hold it. Hit 5? What?
F5.
F5. Where the hell is F5? Huh?
The keyboard.
Where's the keyboard? Okay. I don't. Wait a minute. Hold it. This ought to work. Okay. Problems. How to do this? Let me just do this real quick. I have a problem with people in not being in a situation saying what they do or don't want in it. Okay? like I wouldn't want this or that if this or that happens. Not if they talk about PVS, but I'm almost leery of asking them because some of them will say, I'd want to stick around, and I have a difficulty with that on the score of the gross national product and what's good care. But anyway, the rest of it, let's check. How many of you, if you went into your financial planner and you were offered this living will and you came to the box that said, if I have a terminal illness, I would not want to be treated aggressively, I want to be just kept comfortable. How many of you would check that box and sign it? Well, that's a low yield. What's going on here?
You're not allowing for a distinction between an upcoming illness that is treatable, even though we maintain your terminal illness, and terminal illness. So if you have a terminal illness, but you manage to get the flu before the terminal illness really dominates, then will that mean you won't get treated for the flu?
It could. For what it's worth, it depends on the locality, but in a lot of jurisdictions, if the patient makes clear and specific prior statements about what they don't want, not just we, but the proxies and the rest are obliged to honor that. Okay? So if you said something like, if I have a terminal illness, I don't want to be treated aggressively, and you might have something acute that might be reversible, then a straightforward reading of that, and certainly if we took it to our attorneys, they'd tend to say you can't touch them. You can't do it.
I think it's the problem.
Okay. Is that why everybody else is dragging their feet too?
You have to be unconscious and terminal. So if I'm
That's an or.
no.
When you in the Kentucky one, when I looked, it's vegetative state, terminal illness, or lost capacity. It's a disjunct.
Well, yeah, but you can be
In the form that
awake and able to consent, and if you're able to consent, then your consent is what's going to carry the weight, right? However, you have to be unable to make a consent.
Oh yeah, I mean, none of this has any effect if the patient's available for comment. You just go talk to the patient.
Right. And the problem is people have different perceptions. In the empirical research I did back in the 90s into the 2000s, it showed that when you talk about PVS or irreversible coma, they said, don't do it. But when you talk about terminal illness, there's a huge amount of variability. Because there are people who think, oh, I'm terminal ill, but I might be able to kind of live my life, and I might be able to do things for next several months.
Or do less things, say goodbye, write your disreputable children out of the will,
and so they're
vacation in Zanzibar.
They're projecting a circumstance of consciousness and terminal illness, as opposed to you're unconscious, never to reawaken, and terminal illness.
Okay.
We got to be very clear. Directives to physicians or a living will or a medical power of attorney only apply when the patient has lost capacity.
Right.
A living will, you have to have either. You have to have a terminal condition or reversible, as the statute says. That's a second condition that must be met. But it's not an or. It's one or two and three.
Correct. Right.
Okay.
That is not a disjunctive. That is incorrect.
No, it's correct because there are any number of living wills that you can have the choice of checking the box where all that is going on is you've permanently lost the capacity to make your own decisions. It's not PVS, it's something different, and a fair amount of people check that.
I don't know any jurisdiction that allows that.
Why would they not? The other thing, by the way, that in an advanced directive that usually in a living will you get, there's going to be a space where you could say anything else you want. You can say, for example, don't ever put me on a ventilator. I've seen that often. Don't do surgery. There's a lot of people that would say no artificial feeding and hydration. Even though again, some of those people may end up in a situation where part of an acute response to reversible illness is that. So that's troublesome too.
When a patient has capacity to make decisions, all advanced directives are irrelevant.
Right.
Quality informed consent.
Yep.
The statutes all say that directives take application when the patient has lost capacity. Correct. For the medical power of attorney, that's the only condition. For a living will, there must be the additional condition of meeting the definition of a terminal irreversible condition, or whatever. Florida has permanent vegetative status in the statute. but you must meet the diagnostic conditions stipulated in the statute.
Okay, McCullough.
For living will, it's 1 or 2, and in all cases 3.
My understanding, Dr. McCullough, is that anybody can write their own living will and put anything they want to in it, and they could, among other things, and I've seen this, have number 3 all by its lonesome. Okay? I've seen physicians that sat down and tried to capture any number of situations. As I was telling this gentleman, we'll say, if my PO2 falls below 40 and in the absence of hyperthermia and barbiturate overdose, blah, 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 you can put anything in you want, and at least in New York State, if it's clear and convincing, the legal default is we're obliged to honor that, even though it's a bad idea medically.
Texas, I'll just speak for Texas, if
okay.
the living will says if I lose capacity to make my own decisions, I don't want life-sustaining treatment, that would not be a valid directive to physicians, because you're not a qualified patient. You don't have a terminal irreversible condition. You would then come under
really
the
interesting.
You would then come under the Medical Decision-Making Act for non-terminal conditions.
Okay.
So I doubt that there's any jurisdiction that would allow to create a valid living will under the statutory definitions.
Dr. McCullough, having gone through all this in New York State and how the laws evolved for 30 years, I would bet you the whole ranch out west that you could have a document like that, and I've actually seen them. There are attorneys out in the community that fashion these.
New York State has the worst advanced directives laws in the country and should not be used as a point of departure for the rest of us.
So I would like to go ahead and stipulate for the record then that New York and Texas are indeed different. And from each other.
Okay. Tell us your case.
Yeah, so I have a very interesting case, and actually I think that the chair's ethics committee is helping the rest of my team as we speak.
Hang on, Doris.
Okay.
We're going to let you do the recording.
Okay. So right now I won't tell you where I work or anything. I have a middle-aged patient who has a terminal condition and has a cancer that has affected his brain and his frontal lobe, and he lacks decision-making capacity right now. So yesterday, as a palliative care physician, my team was called in to meet with a family because we needed to elicit goals of care for this patient and find out what his family thought about his preferences, since he isn't able to communicate those to us right now. In the context of the meeting with his mother, his 2 sisters, and 2 legal, well, I guess above 18 years of age daughters, they all said that they wanted him to have a good quality of life, and that meant him being able to be outdoors, to be home with his mother, whom he had lived with, and his stepfather. But they did note that they had some differences on whether on certain things. And the mother noted that she was Catholic and that her imperative was that, you know, she wanted his quality of life to be good, but really wanted to prolong his life as well, and was hoping secretly for a cure. And the eldest daughter said, well, Dad told me some different things, and he told me that he wanted to be cremated. This came up later, and the mother thinks he wants to be buried. And so already there's some problems here, but we were able to negotiate what quality of life meant for this patient, negotiate the care plan, and say that we take things at a day at a time, and their preference was that we hope he becomes decisional with the help of palliative radiation, and he can state his preferences himself. Yep. And we said we would seize that opportunity if it presented itself, but it might not. And then the mother says, by the way, I am the POA and the healthcare surrogate. And I said, please bring those documents. So she didn't. The
mother or the wife?
The patient's mother. The patient's divorced. So today,
surprise.
She didn't put them on the chart, give them to make copies, to have copies made on the unit. I thought this was a little suspicious, and something just didn't feel right. And so when I asked her today, and the patient's still non-decisional, if she could produce this document, she hands me the POA, I review it, it's only for financial reasons, and I review the living will, which was done during this hospitalization, and he did not check the box that says, I designate my mother and then my sister to be my surrogate decision maker. He did not initial it. Okay. And at the end of the document, he signed his name with 2 letters instead of 1. Basically, he signed his name in such a way that made me question about his decisionality when he actually filled out that living will. And it was witnessed by 2 hospital employees, and our hospital policy says that hospital employees cannot witness that living will. So, yes, so then the living will is invalid. And I told the mother that this could be, an issue, and that if this living will was not valid, which I suspected it was, but that I needed to just check to give me some time to figure out how to approach this, that technically the 2 adult daughters would be the decision makers.
No, the wife.
No, there is no wife.
Oh, I thought, okay.
No, they're divorced. So it's the two daughters.
Okay.
The one is 16, one of the 3. So that's just the 2 adult daughters.
Okay.
And they have to have consensus in our state because you have to have the majority. And they actually are on the same page. So now I'm being told that the patient is being considered for palliative chemotherapy today. I don't know, based on his performance status, if he's even eligible, so there might be a question about whether or not this is medically indicated. So this might not even be on the table as a treatment option, but I think, based on my conversation with the daughters yesterday, they would not want him to undergo chemotherapy because it might make him sick and might interfere with his ability to go home. And then the mother has been very clear that she would want any sort of life-prolonging treatment. And so I found this to be a very unusual case of where living wills can definitely not be helpful and maybe misapplied. And I just wanted to bring that up for all of the experts in the room to help me as the bedside provider, and how do I approach the situation.
Okay. A number of thoughts come to mind regarding this. First of all, one of the jobs I think you get done in the first family conference, where the patient's no longer available for comment and you've got the family there, is you make clear who actually would be the ranking surrogate, and so people understand, okay?
And they,
is mom still claiming she has a document somewhere but can't produce it?
No, she's not.
Okay.
She's not. She was uncomfortable. I think she knew this going into it, that maybe this wasn't gone about the right way. But they did all agree that we don't make decisions unless everyone's on board. And we did say, as far as decision making, how do you make decisions as a family, and who is going to decide? They said we all decide.
Okay.
So
let's play with that a little bit. The fact that the lawyers of the state of Kentucky said that the daughters outranked mom probably won't be as persuasive, I guess. Part of what, I guess my thought would be, you got to kind of balance between, they're really the decision makers, okay? And you can insist on that. And it's fair game to tell mom at some point, and I've said this a number of times, you need to understand, in the end, your influence on this decision is going to be through them. That's a legal matter. That's how we have to go here, all right? All the time saying, it really makes sense for all the family to be there, everybody to have their say, and all the rest. Now, that's number one. 2, at some point, how fastidious you are about that probably, I think, would depend a lot on the credibility of the surrogates you're presented with, the 2 daughters. And I would say, in large, it should have a lot to do with what you, from a medical perspective, think the proper care of this patient is, all right? And if those are very dovetailed, then how much time or what I go through to satisfy mom and the rest and get that unanimity, that's very much an individual call, okay? In a certain way, it's their call. I mean, I could imagine sitting there and saying to the 2 daughters, we're talking about palliative chemotherapy. You don't think he'd want that, okay? I'm obliged to tell you, Mom, I'm obliged to tell them, if you tell me right now that you don't want that done, we won't do it. We won't do it. If you want to discuss this further, if you want to start it and you can continue this conversation, that's if you think about it, the surrogates representing the patient can represent a lot of different needs. One could be, what's the family going to be like and our relationship with mom going to be like after, okay? And that's a very individual choice, and you can certainly allow for that too. Right? Larry, David, other. That was my quick thoughts with that case. Let me just run you down through this. Those of you that can somehow manage to stick here, I'll do this very quick. There's conclusion number 1 that you all anticipated, which is every remotely competent patient should designate a healthcare agent. 2, strong suggestion here. Healthcare agent and family should be involved while the patient is of capacity in discussions. Okay? I kind of learned this from, I did a visiting professorship in China, and they were all, not surprisingly, talking about the role of the family and really kind of beat me up about that. But one thing that I came back with, and some of my residents doing, I think we've got into the bad habit of we just go talk to the patient, if they consent and all the rest. I would encourage, certainly if there are major decisions about shifts in care or anything, the proxy ought to be there. Look what they're going to get. There's going to be informed consent, so you're going to talk about where the patient is, what we can do, what deficits they've got, what we can't do, et cetera, et cetera. They're also going to hear what the patient says. They're going to have the opportunity, as a matter of fact, to ask the patient questions. Like, why did you say that? Why did you look at it this way, et cetera, et cetera. Then, when the patient crashes and this is for your sakes, when the patient crashes and burns at 2 o'clock in the morning, you're not going to be talking to a completely uninformed stranger. You're going to be talking to an acquaintance who at least has had an opportunity to discuss this with the patient, et cetera, et cetera. Okay? I think we need to do a lot more of that, just as a regular thing. Debrief patients and families. Is there an important story in the background? I would commend to you the assumption that any family has had a bad death in it. And when you talk about cancer or this, that, and the other thing, whatever you say, that's what they're thinking. That's what it means to them. It requires work. It requires work. You don't do the work, you're going to get bad clinical decisions, or you're going to get pushback when the time comes. Awful lot of that out there. And I would assume it's always out there until you prove it otherwise. The ongoing importance of being frank with patients and surrogates. I'll make this point simply by mentioning that what I assume when staff call me up and say we've got a futile case down in the ICU, the family won't listen to reason. What I first assume is going on there, and I'm right a fair amount of the time, is staff have not been adequately frank with the family as things went along, and all of a sudden somebody popped the old, we need a DNR on them, and they, not surprisingly, rebelled at that. We don't prepare people as well as we should. I'm not sure what you guys are used to here, but we had a new nurse clinical lead in our ICU at the VA, and the first thing she did when she came in was she started saying every 2 or 3 days, I want a family meeting, and we're going to tell them what's going on. We're going to have time for their questions. A member of the medical team will be here, and we're going to keep doing it. It has worked wonders. It has worked wonders for everybody. Yeah.
There is a phenomenon.
Wait, Paul. Wait.
There is a phenomenon among families in which they listen seemingly attentively, but all the time disagreeing, but not openly expressing those disagreements. They're just saying, well, we'll just see about that. And we have encountered them. They're just intractable when you start talking about it. They've got their minds made up about their course of action, no matter how carefully the physicians and others are.
Absolutely, and there's some still out there. When I hear those sort of scenarios, my worry is more, there's so much we can do to diminish that number of people, okay? A lot of it looks as much as an artifact of what we didn't do or did poorly. We weren't frank with them to the point of bluntness. We didn't regularly update them. We didn't get them in a situation where they were encouraged to talk about it with the patient, et cetera, et cetera, et cetera, okay? And we hit them with it. I mean, everybody has a problem giving bad news or talking about it and all the rest. At this point, maybe I'm just too long in the tooth, but as far as I'm concerned, if you can say it and get away with it in front of your your colleagues, then you ought to be able to say, you should be saying that to the family. You should be saying that to the family. We know what happens when you don't. People get more than they bargained for. All of it goes to hell in a handbasket, right? We've seen that over and over again.
I had to just ask one question, because the whole discussion has been from the direction that the patient would want more minimalistic care, and the others, the family, etc., want more care. Do you ever see the opposite, where in fact there's the belief the patient would want more effort made, and people seem to want less?
My idiosyncratic experience is more often it's the patient that gets there earlier than the family, although I've certainly had interesting examples to the contrary. I've been asked to go down and see, well, for example, vent-dependent patients. The families were convinced that the staff were somehow snookering Dad into staying on that damn ventilator. Okay. And I'll tell you, every time I did that, it had nothing to do with the staff. It was that the patient made very clear, well, of course, I mean, what else am I going to do? Die? Okay, could you turn the TV over to 24? Okay, whatever. That certainly happens.
Okay.
Okay? For what it's worth, by the way, that leads me into another point. We should all make sure that the fact of a proxy or a living will tells us nothing about the interest of that patient in surviving and going on and all the rest, okay? One of the things that peeves me is when it's not clear how we should manage this patient that has various morbidities, et cetera, and somebody said, well, how aggressive should we be? And somebody throws in, well, they're 83. And I get real nervous about that, because it's like trying to do it easier rather than a hard analysis. They might be a very good 83. By the way, there was a study, I think, in Canada where what they did was they asked a bunch of people in various age cohorts from 20 to 30 on up what they thought of their quality of life. They had various quality of life issues. Who do you think scored the highest? 70 to 80s. Okay. Have you seen those license plates? You know, no job, no kids, no phone, et cetera, et cetera. That's not a complaint, right? Right? Okay. People do these things because bad things have happened to other people in their family, and they're trying to cut it off. Doesn't mean at all that they want to die. I think just about all of them that you talk to will let you know. Yeah, I want to stick around, and if you can do something for me, I'd be glad to hear it. Most of them, okay? I mean, the people that we haven't talked about is the really end-of-life people that we know that we can talk to them. You're end-stage lung CA, where hopefully the doctor is going to sit down and actually have that discussion. You might very well consider giving us a DNI. In my experience, next time you get intubated, it's not going to be good for you or your family, that sort of stuff. But again, that's not an advanced directive. That's a current order. I'm sorry. I saw you and
Just a question, getting back to being frank with families. I think it's important, even asking the simple question, what have you heard me saying to you today? I mean, I think that's just key, and letting them repeat back.
Key in spades, and it's amazing what you'll get, and it certainly takes some time. But you don't know what they've received unless you do that.
You have a well adult, and if you say, I'd like to talk about advanced directives, their mind may go straight to, so you're telling me that I'm way to die. And they could have not a problem in the world. You think, no, I'm taking this preventative ethics approach here. They think that if that's what we're talking about, sort of in a Navajo sense, if we speak about it, it must be ready to happen. It may happen because we're talking about it. That's why many patients will not fill one out. A patient once told me that. I didn't fill it out because I figured if I signed it, something terrible would happen to me. And I said, you mean sort of like Wile E. Coyote, a safe would fall on your head? and that's what I call it, the Wile E. Coyote phenomenon. There are a lot of people who are well adults who resist the use of an advanced directive because of the magical thinking that's attached to it.
Let me, did you have a question, sir?
I do.
Please.
I've had several times. We have a patient with a properly executed living will and healthcare surrogate. The living will says, if I become unconscious and I'm terminally ill, stop. I don't want the full court press.
Okay.
I direct that treatment be withheld or withdrawn.
Okay.
I direct it.
Right.
The patient is unconscious, not thought to is going to recover, and is terminally ill by universal medical agreement, which is hard to get, actually, sometimes.
Yep.
But anyhow,
I know.
now the surrogate,
which is a named proxy. Which is a named proxy.
A named
proxy.
proxy.
It's not just what the lawyers came up with.
Right.
Okay.
It says, I want the full court press all the way to the pearly gates.
Right.
And so now we have the stated living will and the proxy are in conflict. Really, the proxy's job is not to exercise autonomous judgment, it's to execute the living will.
Right.
And we have, in my institution,
interpret it if it's not clear, and if it's not clear, then it's their task to interpret it. But it sounds like what we're saying.
No, I'm saying it's clear.
It's crystal clear.
And there is an exception. That is, if the patient had a subsequent conversation in which he, particularly if it was witnessed, that would make it far more convincing. But if they said, I've rethought this, that in this circumstance, I would want to have things.
But is the surrogate reporting that?
No.
Okay.
Then, I mean, what it is the surrogate saying, I can't do it, refuses or declines, but they won't step aside. We just have an extraordinarily difficult time acting on the living, acting on the advance directive in the face of what I call the noise in the room.
Okay. Tell you what, I'll just mention a couple of things. In New York State, if you go to the healthcare proxy law, it says explicitly the proxy is to decide on the basis, the first criterion is the proxy is to decide on the basis of the known wishes of the patient. Okay? I mean, I could give you something a little, here's the gold, what the gold standard is and all of that. Say yesterday you'd had a conversation with that patient, deemed them to be of capacity, and you've worked out DNR, DNI, whatever. Okay? Today, you go over there and two things are going on. The patient's bottoming out. They're about to crash. They're about to code. And the surrogate shows up and says, code them, code them, code them.
Right.
Okay? You don't get any more gold standard than that. For what it's worth, and this is both the VA system and in New York State, I've been the one standing at the door with security standing next to me saying, we are not going to code this patient. The patient made their wishes known. Period. And I think that is one of the things that's our job. I'd say, I don't know your legal situation here. It depends on the institution, whether they're willing to support it, et cetera, et cetera. If I were you, let's put it this way, I wouldn't do that solely as an attending. I'd be talking to whoever your ethics consultant is. I'd be talking to your CEO and saying, if legally it's the case, and I believe it is in Kentucky, you have a right and an obligation, ethically and legally, to insist on that, and they get to decide if we're going to just do that. I mean, one way to do this would be if they're really behind you and committed to this stuff, is to say, we intend to do the following to honor his wishes tomorrow, 3 days from now, whatever, you have that much time to get a court of competent jurisdiction to tell us otherwise, or we're going to stop it. Okay, I don't think you could do it right off, but that's how I think the ethics are clear.
One of the things that I try to do, just being pragmatic in circumstances like this, because I've had also these kinds of proxies where they'll say, I can't do this, I can't bring myself to do Y. And I tell them, I'm not asking you for any decision.
Right.
I'm asking you to serve as a conduit, where you're just channeling through this piece of paper. You're saying, this is what Bob over here would want. This has got nothing to do with you. It has nothing to do with your values, your beliefs, your preferences. Whether you have a living will or not, whether you think ventilators are a good idea, has to do with what Bob would want. If Bob were able to pick up the phone right next to him right now and say, given this diagnosis and this prognosis, what would he do? And then I'll give it a quick second, and if they say, well, I think, no, what would Bob want? Because if they're unable to do that, then you have just cause, and I'm not an attorney, nor do I play one on television. However, I would say you have just cause to then seek whatever other legal remedy to say that this person you either ask them, are you willing to step down as proxy and have the alternate go ahead and serve? Or B, to strip them of their ability to make decisions, or to ignore them if you really wish to go out on a limb with your legal counsel and do what the alternate proxy says. Because if the alternate proxy says, this guy's not doing his job, I know what Bob would want. Bob would want X done. And then if that's the person who's representing them and you know the other person is not, then you're obeying with the wishes of Bob through their surrogate. That's what surrogacy is.
And if there is a legal remedy, I'm just not aware of it ever being used.
Supposedly you have to go through probate court and all that sort of thing, but I don't think you should have to do that.
For what it's worth, it certainly got used in various ways in New York State. It's also been used within federal jurisdictions. Sometimes you get burned, sometimes it works. If I were you, I'd certainly send it up the line and say this might very well be a good case to get this clarified. There are certainly states where that has been done. Okay? But, you know, at some point it's kind of like, is the juice worth the squeeze, of course. I mean, how much is the patient going to suffer if we don't honor his wishes would be one question that would exercise me. If you told me that he was permanently unconscious, I'm not sure I would overly expend myself on this. We certainly, well, in the VA and otherwise, we certainly, it's interesting in the VA, it's funny. If it's just an advance directive, then if there's a conflict with the ranking surrogate, we can't insist. We can't do anything unilaterally. It has to go to the National Ethics Center, and if none of this can get agreement, then it would have to go to court. However, if you've got an order there, that we can insist on. If you've got a DNR order, if you've got the mulcts, if you've got a do not intubate, and we've certainly done that. Okay? Arguably, did we miss a bet with this patient in the sense, was there a point at which you could have gotten DNR, DNI, and the rest, which you could have honored? Who knows?
Well, yeah, I mean, the point is the legal versus the PR issue, and I just find the PR issue wins. I mean, healthcare institutions are just so reluctant to push it into the courts to really.
Have you tested your ethics committee and your institution as to whether they're willing to do it or not? And if not, why don't you try that?
That would be a possible recourse, right?
I would suggest it. See if they're willing. Do a trial. See if they're willing to go to bat for this. It sounds like a patient where it would be, among other things, worthwhile to go to bat. Your patient gave you clear instructions. It makes eminent sense medically. This person is not being reasonable, and they're not willing to step aside. They're not. David and I couldn't talk them out of it by a long discussion of substitute judgment. Right? Yeah, I would suggest challenge the institutions, see if they'll do it. Dr. McCullough.
We had a scenario like that in one of our hospitals, and our position was that the directive controls the surrogate was bound by the substituted judgment standard. And legal counsel said if she doesn't accept that, she can go to court and try to stop us.
Yeah, it's hardball, and it's hardball because most people don't have the money, and we've certainly done that too. As simple as that. The patient has spoken, it's clear, we are legally obliged, we believe we're legally obliged to follow it. You've got a day or two to get a court of competent jurisdiction to tell us otherwise. Okay? I mean, a lot of hospitals will say, no, we've got to go to court and get a ruling on that. I go with what Dr. McCullough says. You don't have to do that. You just tell them this is what we're going to do unless you can provide a court to tell us to do otherwise. Okay? Just to finish up, there's an talk more, write less is part of what should be going on here. Okay? Clearly. That's why I said get people in so even while the patient's still with it, they hear what's going on, get a chance to talk to the patient about it. That can be assisted by an informal use of this values history that Dr. McCullough and Dr. Dukas has. You can tell them, go sit down with your proxy and go through these questions and talk about them among yourselves. The why is more important than the what. Too often we worry, well, does the patient want to get coded? Do they want the tube? What you want to ask is, what do they want? What are the goals of care? Okay, so you want to ask them why. Trial interventions, the default, like I think I already said. Most folks, I think, want to stick around. The fact that they've got living wills and the rest don't mean they value life less, okay? They do it because they're worried about end-stage scenarios. Therefore, arguably, the default, if it's a pressing situation, would be a trial. Your moderate COPDer that comes in and they've got bilateral bronchopneumonia, the default there arguably is intubation and antibiotics, and you just have to be prepared to stop if it doesn't work out. And a lot of times you can make a deal. I've done it often with families that get worried he's going to be stuck. You just say, no, they're not stuck. If you tell us to stop, we will stop. Guarantee it. I'll put it in writing. I've put it in writing. So you put that in writing? Yep. Okay. Uncle Al isn't much of a person, but he's still my Uncle Al. Just because people no longer lack capacity, et cetera, et cetera. I've been kind of challenged my colleagues and kind of moved a little way here. There's certainly value in lives that are markedly less than our own. We should be attentive to that too. Again, it's an all things considered thing. I found myself asking, well, do they watch TV? What's their usual situation? It may be something that Mother would be horrified, but the way Mother is now is not horrified. She's actually having more fun than the rest of us. Right? There's 9 really gets down to advanced directives are nice, but actually I didn't do this. The idea of talking about a situation you're not in now is a little bit problematic, right? It's very easy if I'm a healthy person to say, no, I wouldn't want that, I wouldn't want that, I wouldn't want that. I think all of us that have had clinical experience knows that when the rubber meets the road, patients tend to say something different. They may. There's a very nice Spanish aphorism that captures this idea and is a cautionary. It's about bullfighting, and I wish I remember the Spanish because it was beautiful. But the translation is basically, as one moves from the stands into the arena, the aspect of the bull changes. Okay? And I think we need to be mindful of that. How mindful is an issue? If we're too mindful of it, it would blow out of the water any credibility for advanced directives, right? But on the other hand, we should certainly keep in mind that what a patient, while healthy, might say might not be the same when we get to the point where, and we know this, where it's this or you're in the ground. And then finally, proximity to the launching pad. I think there's a real timing issue to get to DNR, MOLST, and all the rest. This MOLST stuff and outpatient DNR, I think, is crucial. Certainly at the VA, we have so many more patients now that we send them home, they're back in the community. While the orders that were current in the hospital, including for limitations, ought to follow them out there. Okay, we don't know where they'll end up. Are they going to drop when they're in the supermarket, et cetera, et cetera? We've tried increasingly to make it part of standard discharge planning for all our patients. As a matter of fact, the expectation is if there was DNR or any sorts of orders like that, there will absolutely be a discussion with the patient before they leave the hospital as to whether they want those orders in the community. And we assist them with that. Can you see where I might have a tendency after all this is to say, tear up the living wills and the values histories and all the rest? Don't bind your proxy to things that were said in situations where the patient was only in the arena. Think of the advantage it is when we sit down with the family and it isn't some vague, well, they're in persistent vegetative state or they have a terminal illness. It's Dad has that whole discussion we have with families. this is what's happened, this is what we've got, this is what we can do, this is what we can't do, okay? The context and the detail of that. And then moving along to what do you think Dad would say if they heard this? Okay, very different, very different. I say that hesitantly. We have 2 minutes. I've left 2 minutes for Dr. Dukas and Dr. McCullough to caution me on that. But that is actually my tendency. My tendency, the way to do this well, is that you as staff are soliciting these documents, you're encouraging them, you encourage a proxy out of everybody. As somebody gets closer and closer to being in the arena, you raise these questions. As somebody gets closer and closer, you start suggesting limitations that might be appropriate and generate orders. Okay, I think that's the way to do it. I think that's the way to do it.
Any final questions?
No question.
Paul?
You have mentioned several times that a financial advisor might be helpful in forming a living will, and I can understand why.
No, I say they encourage you to do it.
And living wills. But one of the things that the person that assists in this needs to have is a skill in conflict management, so that they can anticipate a very dysfunctional way in which carrying out the advance directive might leave the family. And specifically, I take it that you had a tongue-in-cheek or were jesting with us when you said that you had a secret sweetheart that you had named as your proxy.
Oh yeah, of course I was jesting.
But that sort of thing might be...
These two guys know my wife. I mean, I have to be jesting.
This is going on the internet.
Yeah,
but that too.
But the reason I mention that is that if we take seriously the dynamics that such a thing would produce, and I do know things like that have happened,
yep.
That should be anticipated by the person who assists in making out the advance directive. Have you thought about the message that you're sending to your family and how dysfunctional they're going to wind up being when this is read?
Yeah.
Go get their shotgun.
For what it's worth, if I had my druthers, I don't really have, maybe I should, I don't have a problem with financial planners suggesting the proxy. I do have a problem with the documents they also offer where patients get to check various boxes and are encouraged to talk about situations they've never been in while they're still healthy. I have a big problem with that. I think you're more likely to get attention to that sort of thing from staff if they help them. So again, like I said, if we got a patient that doesn't have these documents, we ask them if they'd like to talk to somebody that could help them consider that, and we actually have had a very substantial repeated in-servicing for our social workers who help do that. Okay? Now, you can also go further. You also, with your patients, always want to ask that if they have those, you want to see them. And I would suggest any time you've got an advance directive from a patient, you want to sit down with them yourself and ask them, you know, do you still feel this way? What do you mean by that? There may be very well be any number of questions that come to mind that you want to clarify. Okay? You might ask them a little bit about why you picked that person rather than somebody else. Right? And then we also get into the whole thing as things get indicated. If it looks like that ranking family member or agent is not in the same place as the patient or any of the other things we identified, then you might aggressively encourage the patient to do this. Okay? So that's certainly the prescription. To empower, inform, enable, in a good sense, proxies and surrogates to do their job. It would take care of a host of evils, I think. By the way, my experience is that other family members that aren't named, it doesn't take too much to get them to understand. Look, Dad picked Sister Sue to do this. And what the job is, it sounds like what the job is, the way we usually understand it, he felt above anybody, Sister Sue would have the best idea. You can all talk about it, you've got your input and all the rest, but you might just end up being comfortable with the idea that this is what she's saying, even though it's not what you'd say. Okay? I mean, there are ways we can help people out with this when the time comes. We can leave them with a lot less burden when they walk out of the room. Right? Like anything else, it can be dealt in well or poorly, right? Final thoughts?
Thank you.
Thank you very much. Thank you.